Assalamualaikum.
Waalaikumsalam, Dr. Taufiq.
Alright, let me start now.
All right. Assalamu alaikum warahmatullahi wabarakatuh. Good morning to Dr. Taufiq and to all my friends that's here in this call. So today's problem-based seminar, and I think it's the last problem-based seminar in our whole posting, which will be about short stature. So as usual, sit back and enjoy the presentation while it lasts. So this is our contents. So we'll be giving you a small video in layman terms, basically to tell you basically how people in short stature actually lives. Basically, what is the public perception on short stature? It will be some kind of a comedian movie, which a very well-known comedian, Kevin Hart, will show it to you later, who is able to explain basically his experience in being short. Basically, it's less than 4 feet. Later, we'll give you an introduction, which will include definition, epidemiology, and then we'll include another video, which will be how parents or how mothers usually come to the doctor and how do they actually complain of their child actually being in such a short stature. So how do they actually come to the doctor, and basically explain, hey, doctor, my child is shorter than their friends in school, shorter than their peers. So just in a cartoon character, later on going with a differential diagnosis from a doctor's perspective, history and examination, management. And then we'll have a short summary video. Basically, all the videos will be in around 1 minute. It will be short videos. And then we'll have a quiz at the end and Dr. Taufiq input also towards the end. So without further ado, so this is our first video.
Get so comfortable with how did you get so comfortable with your height?
Oh, I've always been comfortable, man.
Really? Because generally, people who are not 6 feet tall, particularly not people, men, have a complex about it. Instead, you turned it into.
I'm beyond confident.
Sorry, can you guys see the video? Are you able to hear the video fully?
Yes.
All right, perfect. Thank you for your response.
How did you get so comfortable with your height?
Oh, I've always been comfortable, man.
Really? Because generally, people who are not 6 feet tall, particularly not people, men, have a complex about it. Instead, you turned it into.
I'm beyond confident. I'm not cocky, I'm so confident. I'm confident in who I am. I'm confident in the person that I am. I think I'm sexy. I tell my lady all the time, babe, I'm sexy. I just got 2 ugly toes. That's it. That's the only thing. I love me. And
You're sexy with your socks on.
Yeah, I don't take my socks off. I don't take them off, but I wear good socks. That's the plus. I just don't believe in change. I don't believe in doing things to manufacture my body to appeal to what I think people might like. This is it. This is what I was given. This is my playing cards. If we was playing poker, I gotta make this hand work.
Yeah.
This is it for me. And this is what I'm gonna ride out. So how do you not embrace it? You get one life.
Yeah.
One. You get one life. I'm gonna embrace mine.
So when you were younger, did people make fun of you because of your height?
I did it before they did.
You did it before they did?
Self-deprecation. I still, until this day, I'm big on self-deprecation. Anything that the person thinks that they can say, I disarm you of it by saying it myself.
By taking the power away.
I did it in all of my stand-ups, so you can't address it anymore. In movies, what you might think to say, I'll say it in a line, so it's addressed, and then from that point on, you forget about it. It's done.
I'm not the little man, you are.
Hey, don't start this if you don't want to finish.
Start what? What, you about 3'10", 3'11"?
Yeah, but you know what I'm gonna do. Bro, what you gonna do, stretch?
Take me serious and take me in my role seriously. Take my talent seriously. if you give people the opportunity to look at you with a squinted eye, and,
Yeah.
I don't know, then they will.
Yeah.
If you don't,
So that whole scene with Cedric on the basketball court and Think Like a Man, did that come from?
that's me. That's all me.
That's
all me.
you, yeah.
All me.
All right, guys. If the game is what you want, a game is what you're gonna get. You wanna play? Said, let him go.
Cedric.
So embarrassing.
But you disarm them, and then it's not only funny, but now it's grounded and it becomes real. And that's what I love about the projects that I'm doing now. That's what I love about the work that I'm doing now. It's real.
All right, so this is quite an interesting video. Actually, quite explains his experience actually in being short. So he tells actually the world on to take their talent as it is, basically to take what's good out of him and to not look down basically on short stature people as they live a life basically similar to others. They are like the others, the only thing that they might be short. And this will be basically the objective of our presentation today. So without further ado, from a medical perspective, I'll invite the next speaker to kind of introduce and define the topic.
Okay, my name is Ahmad Nurishman. So I will introduce to you guys about the topic, which is the short stature. So as we know that short stature is not an exclusive phenomenon among children from underprivileged group. So it actually happens across income, education levels, occupation, and also ethnicity. So many parents actually are not aware that child height is related to nutrition, health, or overall growth. So what we can see here, height definition of short stature can be defined as height which is more or equal to 2 standard deviation below the mean for the age and sex of a child for less than third percentile on growth chart. And also, it can also be defined as a child with a height less than 1.5 standard deviation, which is 10 cm, which is 10 cm compared to mid-parental height or the genetic target. So the normal variant of growth, which include the familial short stature and also constitutional short stature, or we can say it as constitutional delay of growth and puberty, can be the causes to the short stature or a pathologic causes. Okay, next. Okay, so according to the epidemiology, the definition of the short stature is acquired about 97.5% of the population belongs to the normal and tall stature, and only about 2.5% of the total population is a short stature. So, however, the prevalence rate may vary with the climatic conditions. Right. Previous Murat.
Sorry, I think there is a delay in my internet. Let me shut off my video. Okay, Maman.
However, the prevalence rate may vary with the climatic condition of the geographical area, which stature of a person is the result of the interaction between the genetic adaptation and also the climate condition. So usually this extremely cold climate favors short and round individuals, whereas individuals from hot climates are generally tall and thin. Next. Okay, as you can see here is the prevalence across the world who people have a short stature, which I will explain the prevalence in Saudi Arabia, United States, South India, and also in Malaysia. Next. Okay, so in Saudi Arabia, recorded a relative high frequency of short stature. For example, in boys, there's 11.3% in children and 1.8% in adolescents. However, in girls, there are about 10.5% of children and also 1.2% in adolescents, which we compare it from the definition just now. The total is 2.5% of the total population. So there's increase of short stature prevalence in people in Saudi Arabia. Next. So people in the United States, 555 children out of 114,000 children in United States, which account about 0.48% in the United States had a short stature. This is a reduced prevalence of the short stature in United States. Next. So a study from South India has recorded the prevalence of about 2.86%, which is 448 out of 15,000 in school-going children. So this the study has examined about the 15,000 children has a short stature, which is about 448. So the major reason behind the short stature in South India mostly account for the genetics and constitutional short stature, which account about 66%. And the next one followed by the hypothyroidism, which about 13%, and growth hormone deficiency 9%, followed by malnutrition 6%. Next. So in Malaysia, from the National Health Mobility Survey, statistics has reported that in 2019, there's about 21% of Malaysian children under the age of 5 years are stunted or short stature, which means there's higher prevalence of children in Malaysia has a short stature, which is really worrying. So the highest rate is mostly in Kelantan, it's about 34%, followed by Terengganu, 21%. However, there are no published studies has yet been published regarding the causes of the short stature in Malaysian children. Next. In sex-related short stature, studies from South China has published that boys are more likely to come admitted to the hospital than girls, most likely because of the social pressure and also the expectation come from the public. And mostly the boys likely to have idiopathic growth hormone deficiency or consistent delay of growth and also development. Next. So most of the causes of short stature can be, I have divided into 4, which will more further detail explained by my friend after this. So I will just give the most causes of the short stature, which the first one is the endocrine disorder. The next one is genetic disorder, bone diseases, and also the chronic disorder. Next. So this is the video of when the parents come to the doctor and the doctor explain the short stature to the parent, how the doctor educate the parents.
Stand as tall as you can. Got it. Off you go. He is a little on the short side. Short stature is defined as being 2 standard deviations below the average height for age, gender, and family background. It's natural to be concerned about your boy's development, but short stature in itself is not a medical problem. And keep in mind that children grow at different rates. Some get tall early, and others are late bloomers and get taller towards the end of adolescence. So your boy could be like that too. In rare cases, it can be the result of an underlying medical condition, so it's good you've come to see me. Growth hormone can be an option for some, but its benefits and costs need to be considered on an individual basis. But in most cases, short kids are just short kids, and they're just as healthy and happy as any other. And I've got a feeling this young man is not going to let his height hold him back.
Okay, so I'll proceed next with the differential diagnosis of a child who came with short stature. So my name's Camelia. All right, so as the video previously mentioned, that there are basically several reasons as why a child might come with short stature. And then even the previous presenter also mentioned that short stature can be either of normal variant or pathological. So taken by the definition, which is less than third percentile plotted in the growth chart. So how we can assess a child with short stature is basically by taking detailed history from the parents, by examining the patient themselves, and also by taking the mid-parental target height. So of course, like I mentioned, we have normal variants of short stature. So we have familial short stature and constitutional short stature, or also known as late bloomers. And then for pathological, we have disproportionate and proportionate, to which under disproportionate, we have skeletal dysplasia and also rickets. And then for proportionate pathological short stature, we have those child who presented with dysmorphic features and also those who presented with no dysmorphic features. All right, next slide, please. Okay, so I'll talk first on the variations of normal. So as mentioned, we have familial short stature and also constitutional delay. So in the case of familial short stature, so usually they have a positive family history of short stature, to which it could be either both parents are short or only one of them is short. Gender-wise, most of the time it's both sexes are equally affected, males and females. And then at birth, their length is usually normal. Sexually, they have normal development, and the bone age is also of normal. So eventually, their final height is short but normal for their targeted height. As compared to constitutional delay, so there is a positive family history of delayed puberty, but then the parents' stature are of average. It's not meaning that both parents are not really that high, they are not really that tall. For gender, it's more common in boys, and then the length at birth is basically normal, but then sexually they have delayed in development, which eventually leads to the bone age to be delayed as well. But then once they reach their puberty, their final height eventually normalizes. All right, next slide. Okay, so this is on the differences in the growth chart. So as you can see in the familial short stature on the left, the growth center, it follows within the predicted range for parental height. So and then as mentioned, eventually their final height they're short, but then within the targeted range. As compared to constitutional delay, you can see that the short stature is accentuated by the delayed puberty. So basically, once they reach their puberty, their height picks up, and then eventually it normalizes. Okay, so that's on the normal variants of short stature. The next one, next slide, we have child who presented with dysmorphic features. So first we have Down syndrome. So this is basically knowledge. It's the presence of extra chromosome 21, so to which is also called as trisomy 21. It's the most common autosomal trisomy. And then the incidence in life-born infants is around 1 in 650 live birth. So these are basically the features of a child with Down syndrome. And then later on, click once, Murad, please. Another one time, okay. So eventually in later medical problems, they will have small stature for their age. All right, so that's Down syndrome. Another one syndrome is we have Turner syndrome. So again, the incidence in live-born infants is 1 in 2,500 live birth, to which the cardinal feature of Turner syndrome is basically short stature. So, but then, because it affects females, right? So affected females, they tend to have typical intelligence and normal life expectancy despite them having short stature. Okay, so that's on children who presented with dysmorphic features. Next is we have disproportionate pathological short stature, to which we have skeletal dysplasia. So, okay, so we have achondroplasia. So basically it's a genetic disorder which occurs like more than 90% of the cases of disproportionate short stature or dwarfism. So as you can see, these are the clinical features. So basically they have macrocephaly with frontal bossing, and then they have shortened limbs, they have short fingers, and also they have both legs, and also not to mention the obvious spinal lordosis. So click twice, Murad. All right, so that's basically a child presented with achondroplasia. Okay, the next one is on rickets. So rickets is defined as the failure in the mineralization of the growing bone or osteoid tissue. So basically there are many causes of rickets, but mainly it's nutritional. So first we have decreased exposure to sunlight. Right. And then next, Murad. Okay, so we have decreased exposure to sunlight, and then we have those who had diets low in calcium, phosphorus, and vitamin D. And then we also have one cause, which is intestinal malabsorption, which is small bowel enteropathy, for example, celiac disease, or basically any chronic diseases like chronic liver disease or chronic renal disease. So these are the features of rickets. But then mainly what I wanted to highlight here is that they could eventually have failure to thrive or short stature. Okay, so that's on rickets. The next one is we have endocrine causes, which is growth hormone deficiency. So it's also known as dwarfism or pituitary dwarfism. It's caused by insufficient amounts of growth hormone in the body. So it might be congenital or acquired cause. And then children with growth hormone deficiency, they have abnormally short stature with normal body proportions. So basically the picture you're seeing is two children of the same age. They are basically fraternal twins, but then one is smaller, one is shorter than the other. So this is because the one on the left is presented with growth hormone deficiency. All right, next is we have hypothyroidism. So as the previous presenter already mentioned, it was in India, one of the cause for the short stature is hypothyroidism. So it can be said that it's relatively common. It occurs in around 2,000 to 4,000 live births. Again, the causes might be of congenital or acquired, and then delayed bone age. So the bone age in a child with hypothyroidism is usually delayed, but then they would have a reasonably normal growth potential once the disorder is identified and also treated. Okay, so that is all for the differentials. So basically, there are a lot more to consider when it comes to making a diagnosis of a child who came with short stature, but the one I listed are basically the ones that are pretty much common that we see in the wards. So that's it. We'll proceed with the next presenter.
So next, I'm going to present about history taking and clinical and physical examination for patient with short stature. Next. So for history taking, we need to ask regarding the history of presenting illness first. First, we need to ask the age of onset. So when it is noticed by the parents that the patient is having short stature. So why is it important to know the age of onset? Because we need to calculate the height velocity. And if the height velocity is below than the actual rate, so usually it is a pathological causes. And then we need to ask regarding the growth pattern from birth. Um, because we need to know if the patient we need to help us to diagnose if the patient is actually having a normal variant of short stature. So usually in familial short stature, the patient is still short after puberty, and for constitutional growth delay, usually the patient will achieve a normal height after puberty. And then next we have to ask regarding the age of puberty onset. Because precocious or delayed puberty can cause a short stature, such as in the constitutional growth delay. So we need to know the age of onset of the puberty. Next is this, we need to ask regarding symptoms of chronic illness. Next. So these are the symptoms of chronic illness that we need to at least ask the patients. And these are several. There are more, but these are the one of the common illnesses that can cause a short stature. So we need to ask if the patient is having any gastrointestinal symptoms such as abdominal pain, diarrhea, rectal bleeding, oral ulcer, or greasy stool, to rule out any Crohn's disease, celiac disease, or malabsorption. Malabsorption causes. Next, we need to ask if the patient has underlying severe asthma or recurrent infection before, to rule out any cystic fibrosis or immunodeficiency causes. Next, we need to ask regarding arthralgia, arthritis, uveitis, or rash, to rule out any juvenile idiopathic arthritis, as this is one of the rheumatic causes of short stature. Next, we need to ask if the patient is having symptoms of lethargy, constipation, or weight gain, as one of the endocrine causes of short stature is a congenital hypothyroidism. Next, we need to ask regarding if the patient is having polyuria, polydipsia, or polyphagia, to rule out type 1 diabetes mellitus, and polyuria to rule out any renal diseases. Next, we need to ask if the parents notice any failure to the child, or if the parents notice that the child is having any exertional intolerance, to rule out anemia causing short stature. Because in anemia or congenital heart disease, there is reduced in oxygen to the body. So reducing oxygen can cause a reduce in metabolic rates. That's why patient may have short stature. And then we need to ask regarding weight loss, fatigue, or fever, because we need to rule out the neoplasm causing short stature, such as in pituitary humus that can cause a growth hormone deficiency. Next. So next, we need to ask the birth history. We need to take the birth history antenatally if the mother have any complications of pregnancy, such as preeclampsia or hypertension during pregnancy. And then we need to ask if the mother is smoking during pregnancy before, and if the mother is taking any alcohol, or mother having any infection before. Next, perinatally, we need to ask regarding the gestational age, because a premature child is more prone to have short stature than a term baby. And then we need to take the birth weight, head circumference, because we need to because a low birth weight baby is more prone to get short stature later in life. And then we have to ask regarding a mode of delivery, APGAR score, to rule out any asphyxia. And then we have to know the history of special care if the child is being admitted to an ICU before. And then postnatally, we need to ask if the child have history of prolonged jaundice, to rule out any congenital hypothyroidism before. And then for nutritional history, we need to take the normal diet history of the patient if the patient is having normal diet, or if the patient is actually reduced in appetite, and if the patient is actually have low energy compared to their friend, and we need to ask regarding sleep pattern, because because in infant, if the child is adequately, if the child is being fed adequately or being breastfed adequately, so they tend to sleep more than they tend to sleep more. And then we need to ask any feeding difficulties to rule out Prader-Willi syndrome, to any Prader-Willi syndrome or congenital heart disease. Then we need to ask if the child taking any supplement to give a clue about to give us a clue if the child is having malnutrition or inadequate nutrition that require him or her to have a supplementation. Next is developmental history. We need to ask about delayed milestone or mental retardation, because delayed milestone or mental retardation can be features of the syndrome before. And then we need to ask regarding medical history if the patient is having underlying illness, if the patient is having underlying illness such as mentioned before. And then if the patient is taking any medication such as corticosteroid, as this also can cause short staging. And then we need to ask regarding a family history. So family history is very important because like Afaf said before, it is one of the normal variant of short stature is familial short stature. So we need to ask the parents if we need to ask if the patient have family history of short stature in 3 generations before. And also we need to ask the age of onset of puberty in family members of the same sex. If the child is, if it is a girl, so we need to ask the age of puberty of the girl in the family. And then we need to ask, is there any history of disease in the family such as Down syndrome or Turner syndrome or the syndrome before. And then we need to ask regarding a consanguinity marriage. If the parent is having consanguinity marriage, because usually the short stature is running in family. So if the parents is married to the same family members, to the nearest family members, so the trait will be passed down to the child. And then next is social history. We also have to ask regarding the social environment. If the child is being negligent or if the child is being abused, and we need to take note the school attendance. If the child is frequently absent from class or school, because to we need to anticipate if the patient is actually depressed, childhood depression, or being bullied. So that also can affect the psychosocial function. So the psychosocial function of abnormal psychosocial function also can cause the short stature in children. Next. So next is physical examination. Next. So if patient come to clinic or hospital with a short stature, anticipating a short stature, so we need to observe if the patient is having signs of malnutrition such as muscle wasting or anorexia, and if the patient has any signs or any changes in skin, hair or nails, this can also give clue about signs of malnutrition. And then if we can look at the face if the patient is having kilosis or angular stomatitis throughout any iron deficiency anywhere. And then we can also observe if the patient having Cushing features such as central obesity or moon faces. You can look at the picture. The Cushing's features. And then we need to look if the patient is actually pale or generally edematous to rule out any anemia or renal diseases. And we also need to observe if the patient is having a both legs, frontal bossing, pigeon chest, to rule out any rickets causes, malnutrition causes. And we should also look for any signs of abuse, bruises, a hip wound or hip fracture to rule out the child abuse. And then we should also look at the parents if the parents is actually short or tall. Next. Next is dysmorphism, as been mentioned by Afaf before. Down syndrome and Turner syndrome is one of the common syndromes cause a short stature, and other syndrome that can also cause short stature is Noonan syndrome and also Prader-Willi syndrome. So you can look at the picture. Noonan syndrome, usually the patient will have the neck skin will have a webbed neck skin. The neck skin, you can see. And then for Prader-Willi syndrome, you can look at the picture. There is a narrow temporal to nasal bridge distance, and also there is a thin lips, thin upper lips. Next. So for physical examination, we need the important part is we need to take the anthropometric measurement. First, we need to measure the height, weight, and head circumference. So in below 2 years old, we have to measure the supine line with infantometer. Just put the baby lying down and then measure the sole and tip of the hip. And then for all the children above 2 years old, older than 2 years old, we can measure by using half pendant stadiometer by measuring the standing height. Infantometer, we measure the supine line, and in older children we measure the standing height. So in half pendant stadiometer, the measurement should the child should not have any shoes or socks before shoes or socks on. Next. Next is height velocity. So we need to know the age because we need to calculate the height velocity for the child. So at the age, if he or she achieve the growth that should be achieved. So in prenatal growth, the growth velocity should be 1.2 to 1.5 cm per week. And then in puberty, there is difference between boys and girls. So in boys, it is the growth rate is faster than the girls with 9.5 cm per year, and for girls, it is 8.3 cm per year. And then we need to calculate the mid-parental height. This mid-parental height is used for measuring the targeted height. So for boys, we can measure by taking the father's height plus mother's height plus 13 over divide by 2, and then for girls also you can do a different formula. However, for mid-parental height or this targeted height, it does not necessarily determine the short stature of the patient, because you can look at the picture. The guy is actually from short stature parents. Both of his parents are short stature. However, he can achieve a normal height for his age. Next. And also for mid-parental height, we should plot the targeted height. We should plot the targeted height at the age of 18, because because at the age of 18, normally we will achieve the maximum height at the age of 18. So after age of 18, we cannot achieve. We won't grow any taller. Next. Next is arm span. So we need to measure the arm span. It is important for assessment of growth hormone deficiency, chromosomal disorders, and skeletal dysplasia. So at birth, the arm span, the measuring of arm span is we need to measure the arm span in ratio to the height. So at birth, normally the arm span is 2.5 centimeter shorter than the height, and along the way until adolescent, the arm span should be equal to the height, and in adults, usually the arm span should exceed height by more than 5 cm. So if there's any discrepancy, patient may have skeletal dysplasia, disproportionate short stature. Next. Next is upper segment and lower segment ratio. So we need to calculate the ratio. For the upper segment, it is a distance from middle of pubic symphysis to floor level. And for upper segment, it is a height minus lower segment. So at birth, the ratio should be upper segment should be 1.7 to 1 up to 2 years up to 10 years old. The ratio should be 1 to 1, and more than 10-year-old should be less than 1.3 to 1. If the ratio is more than 1.3, if the upper segment is more than 1.3 to height, so patient may have a short limb dwarfism. The lower segment is lower than the upper segment. Next, the last one is pubertal staging. So we need to examine if the patient is actually have reached puberty or not, because in constitutional delay, in constitutional growth delay in puberty, because in constitutional growth delay, the puberty delay can cause short stature in teenage years. That's I will pass to next presenter.
All right, moving on to the investigation. Basically, I think is to look basically for an etiology, for a cause. Like we have learned that short stature is not a disease, but rather a condition for a disease, or it could be even normal. So investigation will be based on what the previous presenter basically has mentioned. So starting off with laboratory, what do we order? And I'll tell you later basically the causes of the reasons why we order all this stuff. And I think you all can guess based on the previous presenters why these investigations are important. So full blood count, renal profile, urine analysis, liver function test, ESR, CRP chromosomal analysis, molecular genetic testing, TFT, growth factors, growth hormone stimulation test, and 9 o'clock, basically 9 a.m. cortisol test, dexamethasone suppression test, LH and FSH hormones, serology to look for autoantibodies, and in radiological, we have X-ray, CT scan, and MRI. So slowly, one by one. So full blood count is to look for a chronic condition. It doesn't have to be Crohn's disease, but basically it's to look at the hemoglobin level. There is a chronic bleed that is happening, and the most commonest bleed we know is all in the GIT. So it could be Crohn's disease, which is more common. So renal function test, we look at creatinine, calcium phosphate levels to see if there's any renal or bone disorder. So we're looking at the calcium and the calcium levels basically in the bone itself. And based on the cause, you could mention that rickets or skeletal dysplasia could actually explain this. Urinalysis to see the pH levels, to look for renal tubular acidosis. Liver function tests to look at albumin and alkaline phosphate levels. ASR CRP raised in Crohn's disease and also chronic diseases. Chromosomal analysis to look for commonest syndromes, which this is through karyotyping. We know Turner syndrome, we know Down syndrome that has been mentioned earlier, and we know Noonan syndrome as well through molecular genetic testing. Thyroid function test in hypothyroidism, which is a common cause of short stature. Growth factors in growth hormone deficiency, and growth hormone stimulation test is also in growth hormone deficiency. 9 a.m. cortisol level is in Cushing syndrome. Dexamethasone suppression test is also in Cushing syndrome. LH and FSH to look for precocious puberty. If they didn't achieve puberty, they might achieve puberty later, and then they will be normal. In endomysial and anti-transglutaminase IgA antibodies to look for celiac disease. in GIT, and anti-saccharomyces cerevisiae antibodies to look for ASCA, which is a common cause as well. So in X-rays, what do we order in X-rays? Usually it's a skeletal survey to see if there is any condition that is associated with skeletal dysplasia or dwarfism or rickets, for example. So firstly, you can see here is the hand. So we order wrist and hand to kind of estimate the bone age. So if there is a delay in the constitutional delay of growth, and people indicate it either constitutional delay of growth, meaning general delay of growth, or it could be endocrine causes. So in a chest X-ray, to look for chronic lung diseases, like I've mentioned earlier, in chronic cases, you might have short stature. And also in X-rays, you look for achondroplasia, which a picture of an X-ray have been shown earlier, and hypochondroplasia, and to look for also osteogenesis imperfecta, basically on X-rays. So this is an example what I have mentioned earlier. In terms of the hands, in terms of the forearms, the humerus, the pelvis, you could see there's the osteogenesis imperfecta at the right side, and also in the A. So in a CT MRI, we mentioned one of the causes, previous presenter is mentioned is neoplasm. So what is the neoplasm? Usually it's a pituitary adenoma. So if you look for hypopituitarism, basically there's a suppression in the pituitary hormone, pituitary hormone. And to look for any brain tumors that cause GH deficiency eventually. So they could suppress the pituitary gland in not secreting growth hormones. All right, so management, I think if you would basically look into references of management in Sunflower and in UpToDate, you would see that it's mainly conservative because the most commonest cause is familial. And if there is no other management, basically they're on constant follow-up. For example, if we're looking at Down syndrome, we're looking at Turner syndrome, it's mainly reassurance to the parents that this is normal. So this is the mainstay of treatment. But if we have a cause, we need to treat the underlying cause. An example would be if we have hypothyroidism, which is we need to treat with levothyroxine. Basically, we need to give thyroid hormone. If we have an uncontrolled diabetes mellitus, we need to either switch to insulin or basically optimize the diabetes level, the sugar level. Chronic illnesses, treat the cause. Example would be cyanotic CHF, chronic renal failure, chronic infection. We're talking about leukemia, for example. And psychological support for non-treatable causes, like I mentioned, mostly it's mainly reassurance to telling the family that it's normal. It could be familial. There might be a constitutional delay, but once they reach puberty, they will go on. Basically, they will just be like the normal child, basically like normal teenagers. And it's mainly about counseling, parental counseling, like you've seen in the video earlier. Dietary advice, if you suspect there is an undernutrition, then you should basically refer to a dietitian to have the nutritional optimized. Celiac disease, basically it's a gluten. Try to avoid, telling them to avoid gluten basically food. So try to, again, to refer to a dietitian to basically advise on diet that is gluten-free. Renal tubular acidosis as well. So in terms of GH treatment, you will see a video later that this is the mainstay of treatment. Basically, even though the child, you might realize that his growth is somehow delayed, you may give a low dose basically of growth hormone. So in cases where you have pediatric GH deficiency, you might treat with GH. In Turner syndrome as well. And if you suspect also small for gestational age, you might treat with growth hormone. In chronic renal insufficiency, you treat with growth hormone. Idiopathic short stature, Prader-Willi syndrome. AIDS, cachexia, you treat with growth hormone. Growth hormone is a supplement that it's the mainstay supplement basically for short stature. So again, just to treat the underlying cause, if there's underlying cause. If not, then you reassure the parents that this could be normal or this is normal, and you could supply with growth hormone. So growth hormone, how do we give? So this is the dose. Usually it's 0.025 to 0.05, very low dose per milligram per kilogram per day. All right, so we monitor for 3 months interval. Then we see in terms of side effect, clinical response. So we recalculate, we plot in the growth chart in terms of improvement or not. So we have growth parameter in terms of height, weight, and head circumference. And when to stop, the basic answer is to wait when they get normal. So when they reach their final height, in terms of height, velocity, or bone age, which is more than 30-year-old for girls and more than 40-year-old for boys. Oops. All right, so what is the prognosis? So we mentioned that it could be physiological, it could be normal, and it could be pathological. In a pathological short stature where you know where you have failed to treat the underlying cause, or basically until you reach puberty, the early diagnosis and management of preventable conditions can totally improve the condition and accelerate growth to match their peers. Because once they reach their level of no growth, it's already too late to kind of try to optimize their growth eventually. And individuals that have attained skeletal maturity is associated with poor prognosis. And this has been mentioned earlier, like skeletal display, like achondroplasia. And usually the parents or the child might develop as well as psychosocial stress, and it's manageable again with counseling and with reassurance. So our take-home message as a group, we kind of have a list of take-home messages basically from these presentations. Number one is that parents must be concerned of their child because it's their responsibility, as the amount of child with short stature is increasing every year. It could be due to nutritional cause or other causes. There might be many causes of short stature in children, but if detected early, it can be catered to. Prescribing with low-dose growth hormone is the mainstay management basically for short stature. And lastly, family history is really important to diagnose and to have a targeted height measurement. So this is our take-home message as a group. So this is kind of a summary basically of what we have presented all in all in 2 minutes. So I'll leave you guys to actually watch it, and I hope you guys can hear on the internet.
Golden rules. Rule number 1. Remember the mnemonic, construct and never affect the circumference. That mnemonic state the constitutional, structural and endocrinal causes of short stature will save the head circumference and affect both height and weight. Rule number 2, IC2, affect the complete set. Stating that intrauterine infection, chromosomal, or intrauterine central nervous system insult will affect all the 3 parameters.
All right, I think before we proceed with our references, this is the end of our presentation. So would like to hear from Dr. Taufiq, any inputs, any comments, any suggestions, basically.
Right, thanks. Maybe I just want to check the audience now. Omil here, are you there?
Yes, doctor.
They mentioned 2 normal causes of short stature.
The first one is familial short stature, and the second one is constitutional.
constitutional delay in growth and puberty, yeah, CDGP. All right. Next, Siti Aisyah. Siti Aisyah. So Siti Aisyah is absent, yeah. Okay, next, Sarifah.
Yes, Doctor.
Okay, Sarifah. Do you treat celiac disease with growth hormone or not?
Celiac disease? No, Doctor.
Okay, why?
Because in celiac disease, patient with celiac disease, they do not have growth hormone deficiency. They have problem with the guts.
With, sorry? What's the problem?
With the absorption of the nutrient in the guts.
Okay, good. All right. Last one, I think. Masih banyak lagi ya, sorry yang tak buka video nih. Nurul Hidayah.
Yes, Doctor.
Okay, Nurul Hidayah. Mention or list a few diseases that you can give growth hormone.
Sorry, Doctor, what?
List few diseases that you can give growth hormone. In what situation, on what disease that you can give growth hormone? Tak tahu. Okay, pass to others. Nur Alicia.
Turner disease.
Turner apa? Bukan Turner disease.
Turner syndrome, Doctor.
Turner
syndrome.
syndrome.
Patient with growth hormone deficiency. Patient with
Okay,
growth hormone deficiency.
Turner syndrome tu
Patient with
what's the causes?
constitutional.
Stop dah. Turner syndrome tu what's the cause? What happened with Turner syndrome? You are muted lagi ya.
It is a X-linked genetic disorder, Doctor.
X-linked genetic disorder. Syuhada Hadi. Syuhada Hadi. Alright. Can you help to answer? What happened in Turner syndrome? Tak boleh. Okay, Ali.
Yes, sir.
Okay, what happened with Turner syndrome?
Turner syndrome happens when there is absence of one X chromosome.
Okay, so it is 45XO ya. Siapa tadi yang salah tadi? So it is not X-linked recessive. The patient with Turner syndrome is female XO. The female patient that only have one X chromosome. They lost another X chromosome. So due to this XO2, one of the problem is short stature and have deficiency of growth hormone. So giving growth hormone will helpful for those patients. Okay, next, Ani Sophia.
Can you hear me?
Do you give growth hormone to patients with Down syndrome?
Down syndrome? No.
Okay, reason?
Because the cause of the short stature in Down syndrome is not due to growth hormone deficiency.
Tak dengar sangat lah your voice ni. Murad, can you help to answer? Down syndrome? Murad?
Yes. Yes. Can you hear me, doctor?
Yes, clear.
I believe so.
So, what happened in Down syndrome? Why don't we give growth hormone?
Why can't we give growth hormone? Is that the question? My answer is yes, but it could be maybe it makes no difference in terms of their growth.
Yeah, actually a simple answer. Yeah? Because in Down syndrome, there is no problem with the growth hormone. The growth hormone level is not deficient. So it is no point we give growth hormone. Yeah? The problem in Down syndrome, yeah, it is due to the other situation. Okay, alright. Okay, so masih banyak lagi yang tak buka video nih. Masih nak saya panggil lagi ke nih? Anissa Rashidan.
Yes, Doctor.
Oke, dah ada Fatin Hanani.
Yes, Doctor.
Ada Afik, ada. Afik, are you
yes,
there?
yes, okay.
Okay.
Yes. Yes.
Alright, so basically semua dah ada ya. Just I want to open for question first lah. Because the presentation all are okay. Yeah? So you can learn from the slide. How do you make approach of if you have patient with short stature? So short patient not always abnormal. So first thing to do is to assess, to define whether it is normal or abnormal. If it is familial or constitutional delay, so it is normal, so let it be. So if it is not, you need to further investigate whether it is endocrine problem, metabolic problem, genetic problem, chromosomal problem. So start with investigation. Yeah, of course, history and physical examination, and then investigation. And then lastly, treatment. Treatment depend if the growth hormone is deficient, so we give growth hormone. But if the problem is other situation like celiac disease, the problem is the problem with the absorption, yeah, we treat the disease, the absorption problem, not giving growth hormone. That simple, yeah. Alright. So any questions yang tak clear lagi? Any one of you?
Doctor, I have a question.
Yes.
For the mid-parental height, for the mothers and fathers height, do we use the current mother father height? Macam Doctor? Because the father and mother's height can reduce right when they become older.
Reduce, are you sure? Nah, siapa yang answer yang
Sebab
present with the
dia
method?
apa ni? Dis
I think the third presenter ya. Siapa tadi? Nazira ya.
Yes, Doktor.
Okay. Nah,
Usually, the mid-parental height, we will calculate before the age of 18. Maksudnya sebelum jadi 18 years old, kita calculate. So before 18, usually our parents still within the yang height yang maximum.
before 18 or after 18?
Before the child is 18 years old, usually the mother or father is not in the old age or is not in the yang
Optimum or maximum height. So, yang the one that you use is height of parents. Masa umur berapa? Ya, of course parents kan usually kan jarang, very rare you have parents yang below 18. Parents tuh usually 25, 30, or maybe 40 and above. Ya current height lah you use. Because after 18, there will be no more increasing in height, no more growth. Maybe in some situation we can wait until 21. So basically, almost all parents who come to our clinic, their age above 18, above 21 kan. So you just use the current weight, current height. So your concern about the height not reduced tuh, actually it is not ya. Kalau orang dah tua tuh geriatric patient nampak lagi pendek, not due to the reducing height, because their posture yang dulunya dia the spine tuh very it is normal spine, lagi tua sometimes there are some condition that the muscle weakness dia jadi kyphosis, sometimes jadi lordosis. But actually if all geriatric patient tuh you properly measure their height, actually they're same from 20 years old, and then you compare masa 60 years old, 80 years old. Kalau dia berdiri betul, so you tengok tadi how you measure the height. The patient must be stand firmly, berdiri tegak betul. So bukan tunduk-tunduk, bukan ngiring-ngiring. Not in sleeping position, must stand and must memang dia touch or memang on the wall, betul-betul kat dinding kalau boleh ya. So that's why the stadiometer yang baik betul tu memang kat dinding, bukan berdiri kat tempat kat any place. Must stand on the wall, just next to the wall. All not all there are some points of the body that must touch the wall. For example, the heel, both heel must touch the wall, and then both buttock must touch the wall. Both shoulder must touch the wall, and then lastly the occiput. Memang kena tegak betul, bukan dengan tunduk, bukan dengan duduk atau tidur. If the measurement not in that position, so that's why it's not proper. Sometimes jadi kurang lah tinggi ke apakah. So it is that simple ya. So actually the height is not reducing. Actually the posture lah yang abnormal or improper posture will give wrong data ya. Okay. Yang tanya tadi siapa tadi?
Oh, okay, Doctor.
Sarifah. Alright. Okay. Next question from Sarifah ni just tambahkan lagi ya, add on. After you get mid parental height, so how the parents kan umur tua kan, dah adult age, maybe 20, 30 or maybe 40 kan. But the kids, for example, maybe 2 years or 5 years old. So how do you know the height of the patient is normal, is familial short stature?
When we get the mid-parental height, we will extrapolate as the presenter said to 18 years old. And then based on the graph, if the patient's height is within 5 centimeter, then is normal, meaning that is a familiar short stature or within the normal range lah.
After you put
mid-parental height tu.
the mid-parental height on the in the growth chart of 18 years old patient, you make an imaginary what we call it line ya. So the curve too. So maybe the curve, for example, mid-parental height lie on third centile. So you make tadi make range tadi. Actually boleh 10 ya, 10 cm above and 10 cm below, and then make imaginary line, make imaginary curve supaya nampak. Ada tadi gambar tadi kan. So, kalau memang if the mid-parental height plus minus 10 itu memang below the centile, ya it is normal. Okay, alright. Okay, any other questions maybe?
Doctor, just two simple questions for me. Hello, my name is Hafiz. Two simple questions. The first one, I would like to know if there's any kind of provided that the child is very short, right? The size is short without any underlying disease like slight disease or what. So is there any specific diet to increase the height? We all note that currently nowadays there are lots of what we call products selling to increase the height, supplements, right? So I just want to know from your expert's opinion about that. That's the first one. Second one is there any kind of surgical interventions that we can offer to short stature children to or like cosmetically done or what? All right. Okay. Thank you, Doctor.
Yeah, I think Murad need to answer this. First about supplement.
Yes. So I think in terms of supplement, we've mentioned is if there is a nutritionary requirement, then yes, definitely. In terms of, I think we highlight in terms of currently now you have high protein diet. In terms of beans, I think chicken, almonds, stuff like that. That will increase your protein diet. This is, I think, in terms of nutrition, but it's important to highlight that this is medical nutrition. So if they have a nutritional deficiency or undernutrition in a specific diet that they're having, then definitely they need to adjust their diet, and then they will grow hopefully normally. But if so, they didn't grow. Moving on to the next question here, I think you've mentioned surgical intervention. I think surgical intervention is not done for pediatric age, based on what I've actually encountered in terms of articles. They've mentioned only when they've already reached the pubertal age, meaning only after puberty, only when they have encountered their full growth, then there is some orthopedic aesthetic basically growths that they might do. Either they have an orthosis under their feet, or they might even cut bone and put orthostatic, but I think it's only 2 centimeter or 3 centimeter in terms of growth. But again, this is not medical, and this is not, I think, related to pediatrics itself. I think this is later in orthopedics and in growth, later in growth. Yeah, other than that, I think maybe doctor, you can add on.
Okay, all right. The first question, yeah.
But I think,
yes.
But I think in terms of surgical intervention, I think it's better done in the pediatrics group, right? Because the bone is still growing, so hopefully the bone will heal much better than the older age group. So
because
what do you think?
You can touch the growth pellet, growth what is it called? Growth line.
Growth plate.
Growth plate.
Yeah, basically the growth plate, this kind of growth plates, you can't actually touch it. So if you touch it, it's gone, then you might have all this LLD, you might have limb length discrepancy. So I think if there is, a surgical intervention of me, if not knowing, maybe doctor can add on.
Okay, Hafiz, wait a minute, yeah, I want to explain further first, yeah. For the first question, tadi sama actually, just any case of short stature, first always diagnose first, yeah? Assess first whether it is normal or abnormal. And then if it is abnormal, is there any growth hormone deficiency or not? If it is growth hormone deficiency, first if it is normal, familial, and then constitutional delay, so no treatment needed actually. Yeah. What more for CDGP itu, just wait for the puberty, the growth will be there. If familial, maybe with adequate with optimum nutrition, maybe can help to achieve maximum height potency. Yeah, of course from the mid parental there are potency kan. It can be lower from the MPH, it can be higher, that it can be lower up to 10 cm, can be higher up to 10 cm from the mid parental head. So to achieve maximum potency tadi, for example, mid parental height only 160, but want to achieve 170. So of course need adequate nutrition. Nutrition for growth is mainly protein. Yeah. Protein too, the best one is animal protein. So meats, fish, and so on and so forth. So how about what about supplements? Supplement is only the product that sell in the market. So of course any producer, any seller wants their product to be sold. That's simple. If you want to get want to achieve maximum potential height, with adequate nutrition only, with adequate protein, no need supplement actually. What more if the problem is growth hormone deficiency? So supplement is nonsense. You give any supplement, so many supplements will have no effect. The one that give effect, you give growth hormone. Another situation yang abnormal ya tadi, if there is another underlying disease macam celiac disease, you give supplement also will not be absorbed. So you must treat the celiac disease, not giving supplement. Okay, yeah. Is it clear for the first question, Hafiz?
Yes, doctor.
So my comment, general
about
comment.
the first question.
Supplement is, of course, every seller wants their product to be sold, sorry. Yeah. You give or don't give, there's no evidence. Again, no evidence in if you want to further investigate, you must have evidence. All the supplement itu memang no evidence lah. Treatment is evidence-based medicine. Ya. Kalau tak ada evidence, please don't give. You ask a doctor, please don't sell those products. Ya. But if if you are a seller, yeah, of course you want to sell. Okay, all right. So next question about the surgical intervention, the one that you you imagine tadi, if there is growth plate punya transplant, maybe it is in the future lah. But currently we we don't practice that. We haven't have adequate knowledge and skill to do that lah. Maybe in the future, maybe if you live 50 or 100 years from now in the future, maybe there will be a growth plate transplant. Yeah. But currently, it is not a practice lah. Still no adequate knowledge about that. The one that siapa tadi Murad explain mas pasal maybe bone punya transplant, maybe it can be done, tapi again it's not significant kan, because only 2-3 cm. Yeah, the one that if it is bones problem, yeah, we optimize the growth plate again with adequate nutrition, meaning protein. Yeah, the macronutrient is protein, the micronutrient, yeah, some ingredient that help for the growth, the bone growth, ya, macam calcium and so on and so forth. Okay. All right.
Thank you, Doctor, so much.
Okay. Welcome. Good. Siapa Nafis, you have good vision. Tapi lah, kalau you nak jadi spesialis, you can explore more lah. Maybe we can do growth plate punya transplant. Okay, all right.
Inshallah, Doctor. Thank you.
Okay, next question. Yeah, finish. All right. So go back to Murad.
We have a quiz.
Yes, you are moderator also, kan? You can.
We have a quiz.
Yes, all right. Proceed.
All right, perfect. So yeah, just I think we have actually encountered Dr. Taufiq in orthopedics, where they have something called Ilazarov, where they grow their bone in the middle, but not in the growth palate. But this is done in the older age group, if it's like a cosmetic part. But imagining that you have Ilazarov in both limbs, lower limbs, it will be painful, it will be costly, and it will be basically just a waste of time. Okay, Nafis. So moving on to our quiz. So we have a quiz already ready for you guys. So we can start it now. So I hope you guys can see my screen.
Yes, clear.
All right, Dr. Taufiq, you're free to join as well. Let me share the link in the chat box so that all of you guys can actually log in directly. So this is the link that you can actually join. And once all of you guys are joined, so maybe around 20, we expect around 20, hopefully, and we can start basically the quiz. So the quiz will be a mixture of some theoretical questions, some are really basically, I think, more of a riddle question. just to make you guys wake up a bit. So some basically are not really related to the topic, just general questions. So I think we can start since we already reached 20. So maybe we could wait a couple more seconds and then we can start, inshallah.
Any prize given to the winner?
Yes, we do have a prize. I think you guys can claim with Maman, Ahmed Usman. So yes, we do have a prize.
Yes. Kalau pakai handphone, if you use handphone,
Yes,
lebih difficult.
Oh, no, actually, this is quiz. So basically, I think you can see the questions also in the website that you have logged in. So you can see the question and you can see the answer as well on the quiz on the website itself. So you don't need the screen. You can look at the screen zoom if you were to wish to see the leaderboard, for example, or so. Yeah, doctor, if you're willing to join as well. So maybe we can start in 5 seconds. Oh, people are still joining. All right, we can start then. All right, so we didn't have everyone answer. I think we have 2 of you didn't answer. So I think here is really important that we, each question is 10 seconds. So hopefully you can start with time yourself really well. So the next question. This is an interesting answer, but yeah, promise. So some people actually mentioned that others use your clothes more than you, which is interesting. So this one got a majority wrong. I think what month do people sleep the least is, I think, February, because they sleep, I think, only 28 days or something like that. Next question. All right, I think that is the end of all the questions. But I think you still, I think you don't know the right answer of where did you graduate from, Dr. Taufiq. So shall we, I think majority that, oh, a lot of people actually know. So 9 people knows. I guess some of you guys, the rest of you guys didn't Google your lecturers. You don't know much. So this is actually where he was graduated. Yeah. So this is the right answer. The next one, which is true, any arm span measurement, which we mentioned about it. So this is the end of the quiz. Yes. So let's see who's the first, second, and third. It's taking some time due to the internet. All right. So first place, Maman, or whoever you are. Second place, Captain. Third place. So yeah, third place is ABC. So yes, absolutely, you guys can claim your present laters. And so the toughest question was, what month do people sleep the least, I think. Okay, I think that's the end of the presentation. If there's any more crashing or last words from Dr. Taufiq, and we can end our presentation.
No need lah. So already discussed just now. All right. You may close.
All right, thank you so. Sorry, Dr. Taufiq.
You may close. You may close.
Okay, so thank you so much, guys, and thank you, Dr. Taufiq, for being with us today, this morning, so we can end our session with Tasbih al-Kafaran Surah Al-Asr. All right, thank you so much,
Thank you,
Dr. Taufiq.
Dr.
Assalamualaikum.